All right, we're ready when you are.
Fantastic. So real quickly, I just want to confirm, what is our time like?
We have an hour, 2 hours.
Oh, okay. Well, we don't need that much time. We're talking
Okay.
about 50 minutes. And then if you wouldn't mind, I'll get somebody else coming in, it looks like. Ursula is our local representative, so she's participating. Question for you, just a little background. It's been a little while since I think we set this meeting up. And so maybe just give me a little bit of feedback in regards to sort of questions you have, concerns, what are your goals, I guess, overall? What are your biggest challenges?
So we want to start incorporating this into our hygiene visits. So the hygienists are going to do it before the doctor comes in. So
Fantastic.
None of us have been trained.
Okay. Well, so you've never had exposure with VELscope before, if I'm hearing correctly?
So the doctor has been doing it, but we're trying to incorporate it into the hygiene visit.
Okay, so you've seen it being used. That's my point. So, okay, fantastic. No offense to our doctor, I really find, at least when I look at practices that really seem to be the most effective and efficient, it's when the hygienists do it. Only because
I know.
they.
Well, can you hold on one second? We're gonna try to figure out the volume here. We can't hear you.
Okay.
I don't know how. Switch to phone. No.
Ursula, can you hear me?
I can hear you fine. Can you?
I think it's us. We're all the way up, but.
Do you have a cell phone?
We do.
What happened?
Do you have a cell phone?
You can call on your cell phone and then put that on speaker.
Oh, we can put it on there. Wait, hang on a second. We can put it on the
Do you think
TV.
that's gonna get louder?
You could turn it up.
That's what happened with me. I dialed in at 10 o'clock on my computer and I'm not getting any visual. So I just dialed in on the phone and I get the visual, and obviously you guys can hear me. So.
Oh yeah, we got it. Hang on.
And I'll apologize up front as I slurp because I have to have my coffee and I was rushing before we got started. So.
Did it go up?
Testing.
No.
Check 1, 2.
All right, so let me try to, I'm gonna call it on my cell phone. Do you have the, yeah, but then I think it's gonna be,
Can you
Yeah.
mute your computer?
that's true, yeah. Okay, hold on, I have Zoom. Do you know the,
Like the login.
yeah, the login?
It does.
What's the meeting ID? I'm sorry.
Hold on, I'll pull it up for you right now.
Oh, that could turn off video and don't, okay.
Hold on, let me, I'm sorry. Pull this up. The meeting ID is 951-800-74800.
Is that clean?
You're in.
All right, hold on one sec.
Recording in progress.
Let me,
There you go.
okay, let's try again.
I can hear you. Hey, a little background. Can you hear me?
So what I'm gonna do is mute myself. This way there's no background. But we
Okay,
can hear you. Unless we have a question, I'll raise my hand.
there you go. But your gear is fine. Awesome. I'm sorry, unmute real quick.
Okay.
How much are you charging for your VELscope?
Nothing. We haven't really talked about, we weren't charging for it before.
Okay, and are you looking to charge this time or no? Or
I think
now?
we're gonna charge out for it and see if any of the insurance companies pick it up, but we were kind of looking for advice from you guys.
And is there a code?
Yes, okay, so we'll go through that. I just want to make sure we're on the same page. As I go through it, it helps me understand sort of how we're going to approach it when it comes to your patients. Okay, awesome, thank you.
Great.
All right, so let's get started. And again, I say this in all sincerity, thank your doctor for me, please, and thank you for participating. We are launching a new goal this year that I'm really excited about, which is, in the next 5 years, we want to reduce oral cancer by 20%. And to do that, we need to screen every patient we possibly can. And so with that, hopefully, as we go through this, if you have some questions, just, I guess, raise your hand or what have you, and we'll stop. So I think one of the things we wanted to really stress is that this is about prevention. This isn't about oral cancer detection. And I know this is really where we talk about oral cancer, but our goal is not to find oral cancer. Our goal is to prevent oral cancer. And the only way we can prevent oral cancer is finding it before it becomes cancer, right? Just like mammograms, just like pap smears. And so at the end of the day, that's where the real benefit of this tool is, helping us prevent oral cancer by finding things early. Now, when we look at oral cancer, so I think it's a scary visual here in that we're seeing oral cancer increase at a pretty dramatic rate. If you see what it was like in the 70s and 80s when more people smoked, right, you can see it was pretty level. And look how it started to increase in terms of that rate. And we think, why would that be? Patients are actually smoking less, right? They tend to be healthier to some degree. But when we look at projections, we're going to see that number continue to increase pretty dramatically. And I've been with the company for over 10 years. And in that period of time, we've seen a 50% increase. And if I told you that breast cancer was increased 50% over the last 10 years, I guarantee you'd be hearing about it in the news, and people would be testing the water and the air. So I say that because one of the things that as we converse with patients, you become ambassadors for this cause about how important it is to be screened. And from that helps the patient understand the value of what you're doing, the value of the charge that you're going to be offering to your patients. So, one of the things that I would ask you, and obviously we're presenting something here, but if you ask most patients, Mrs. Smith, what do you think are some of the 10 to 15 cancers, top 10 to 15 cancers out there? People say colon, breast, skin, cervical. Most women will put cervical, lung, but no one ever puts oral cancer in that ranking. And the reality is you're 4 times likely to get oral cancer now than cervical cancer. So I think what this comparison says it's more about optimism, because at one time, cervical cancer was the leading cause of cancer among women 50 years ago. But with the advent of screening regularly, it has now become a 20th ranked cancer, right? Unfortunately, the only women who get cervical cancer now are predominantly women who don't get a pap smear regularly. So it tells you what the opportunity is if we could screen patients more regularly. But I think this is an eye opener for your patients to say, Mrs. Smith, there's 4 times more likely to get a oral cancer than cervical cancer. Now, this is the thing too, as women, I think you can have this conversation more readily in that we talked about that graph and how it's going up. The key though is, why are we seeing this increase? And now where this, I would say every woman in your practice, I'm sorry, who's an adult, should never decline this. Mrs. Smith, you have an annual pap smear, correct? And the predominant reason why we're doing an annual pap smear, you're having an annual pap smear, is to identify changes specifically associated with HPV. HPV is the leading cause of cervical cancer. But you know what, Mrs. Smith? HPV now is the leading cause of HPV is the leading cause of cervical cancer. HPV now is the leading cause of oral cancer. You have an annual exam for cervical cancer. We are doing now an annual exam for oral cancer because unfortunately of this virus that is now causing. It's not smoking or drinking. And this is so important because your patients think, well, I don't smoke. I'm not a heavy drinker, so I'm not at risk. And this is because no one understands about this link. So again, as we educate our patients, it helps them understand how important it is. One of the things more for your education, but some of the initial studies that this virus was being transmitted via oral sex, right? And so, which is why we start seeing it in a younger population. But what they've shown now is the virus can be transmitted just through open mouth kissing. So what does that mean? That means everybody is at risk. That means every patient in your chair is at risk for oral cancer. Now, I know it sounds like I'm being hyperbolic, but predicated on the criteria for risk factors, we now can put literally anyone, unless they've been living in a bubble, is theoretically at risk for oral cancer. So this is some of the things that we're going to be talking about with some direct-to-consumer initiatives that we have towards educating patients. And that is, number one, 70+% of oral cancers are caused now by HPV, 70. This is coming from the CDC, okay? Number two, there's studies now that show that if you've had an abnormal pap smear, you are at higher risk for oral cancer. Therefore, you need to be screened for oral cancer. And this is just women, right? Obviously, men aren't getting tested for HPV. So with that, we just have to assume that men are exposed. In fact, men do have a higher rate of oral cancer for a variety of reasons, but HPV is now the leading cause of that oral cancer. So who are we going to be offering this to? Look at this. Anyone, definitely, when we look at risk factors, anyone over 40, anyone, we don't even put it in there, but anyone that's had more than 2, sexual interactions. And that's, again, these are CDC guidelines, but it doesn't matter. If you're an adult tobacco smoker exposed to HPV, which is basically everyone, a poor diet, who doesn't have a poor diet nowadays. So any patient in your practice that deems as adult, we are going to offer this to. And we're going to offer it at least once a year, between conversations with your, excuse me one second, between conversations with your doctor. If you have a patient of a higher risk profile, you may want to consider screening them more frequently, whether that's because they have a risk of oral cancer in their family, they're a previous smoker, they have some type of immune deficient or compromised situation, then you can consider screening more frequently, but usually once a year is our standard or recommended standard for care. So of all the slides that we're going to go through from a screening perspective, this is probably, I think, the most important because it's critical to understand, predicated on FDA indications, VELscope is part of your white light examination. So what does that mean? That means that, forget VELscope for a second, if you're doing an oral health examination, it should first start with a health questionnaire, right? So I'm assuming you get an update of the patient's medical situation. Has their prescriptions changed since you last saw them? Has their health condition changed? All the things obviously that could impact them orally. Then it's a Q&A with the patient. Mr. Smith, has anything new changed since last time you were in? Anything we should be concerned about, lumps and bumps or things that you may have noticed. Then we're going to do an extra oral examination, right? We should be palpating extra orally to determine if we feel any lumps or see any lumps that obviously could be of concern. And then we do a white light intraoral examination. As we do our intraoral examination, Mr. Smith, I noticed a little irritation on your cheeks. Are you biting your cheeks? Oh, okay. Yeah, I noticed this little thing in the roof of your mouth. Do you remember jabbing yourself or something? I'm not sure. All right, so we'll keep that mental note. So when we do our VELscope exam, then we can assess, but obviously that feedback from the patient is really important. After we've done our white light exam, we're going to follow that same protocols of that intraoral white light exam with the VELscope. So one side, if you start on the left side, work your way over, vestibule, right side, floor of the mouth, palate, whatever your protocol is, and then back of the throat is critical. But the key is that now all this information that we've garnished, as we're looking through the VELscope, Mr. Smith, yeah, I see your cheeks, you're definitely biting, but I can see it's just irritation, that area on the roof of the mouth. And we're going to go through how do we assess. I'm not really sure. I'm going to, it looks like you maybe have some irritation, but, obviously that's something you want to consult with the doctor. How do we determine if it's something of concern or not? Let's say there is something of concern that we're not sure. And again, we're not diagnosing. We're just identifying areas of concern that are of concern that warrant further examination, or areas of concerns that we can say we're just going to monitor. If it's an area of concern that we want to consider further consultation, then at that point, follow your standard protocols. Unilateral ricochet persists for 2 weeks. It's it's not resolving. And then obviously in consultation with your doctor, you determine this probably needs to be referred out for a specialist review. So if you think about it, 30% of your patients have some form of abnormality, right? Whether it's cheek bite, whether it's a fibroma, but 98% of the time, it's something that you and the doctor determine is probably nothing of concern, right? Or it's benign, or your monitor. At the end of the day, it doesn't matter if you think it's benign or not. We should always have a diagnosis, and this is critical from a legal perspective. And actually, hopefully, VELscope is actually going to assist in determining most of the things you see clinically are actually benign. But again, we always stress assessment and therefore diagnosis always should occur. And if you can't achieve it, please refer out, even if you think it's something that's benign. So when we look at our, the goal, if you will, we mentioned reduction of oral cancer. The only way we're going to reduce cancer from occurring, which is on this far right panel here, is by finding it early as possible. Usually there's a progression, and it's going to vary, mild to moderate dysplasia or precancer. I think a very important thing to note, again, I'm going back to that graph, 70% of oral cancers are found at 70% of oral cancers are found at a late stage, meaning our survival rate is going to continue to be about 50%. When we can find it earlier, we move that savior rate, if you will, to 80, 90+%. We do that by finding it early. The challenge for you as clinicians is it's hard to find those early changes because of below the surface with the naked eye, and that's where VELscope comes into play. So for your information, so we're presenting to the patient, and we're going to go through some examples of how we can present it. But let's say the patient says no. And our first inclination is that they don't want to accept it because of the price, right? It's always important to ask why. Mrs. Smith, this is something that we think is so important. Can you help me understand what your concerns are, why you don't want to move forward? It may be I wasn't expecting to pay the $20, $25 today, but it'll be interesting to hear that you'll find patients say, well, didn't we just do x-rays already? I really don't want any more exposure, or I'm already sore in this area. I just don't want any more discomfort. And so why that's important is because one of the things we always recommend as you're presenting this to the patient, let them know, Ms. Smith, this is painless. It's fast. It's harmless. There's no radiation. There's nothing that cause cellular damage. And so whenever you hear that concern, you can say, Ms. Smith, the great thing about this technology is there's absolutely no discomfort or pain or anything that's going to cause damage to your tissue. It's a safe blue light. And, sometimes it's helpful just to turn it on and show them this is safe blue light kind of thing. So from that, for your information, what we're doing is we're going down to the basement membrane. That blue light is exciting collagen in the basement membrane. When the collagen is normal and healthy, it actually absorbs that blue light and gives off a response. And when we look through the filters, through the handpiece, it actually blocks out certain wavelengths and tells us specifically that the tissue is in a healthy state when it shows up as green. When we have precancer or cancer, and a couple other things we'll talk about, it can't respond because the collagen is starting to break down. And once that breakdown occurs, it can't fluoresce. It can't give us a response. So instead of seeing green, we see dark or black. It's really that simple. Now, it doesn't mean we have cancer. It doesn't mean we have 3 weeks to live. It means there's an area of concern that we have to investigate further, and we'll go through that process. So these are all the things that are involved in assessing if the tissue is normal and healthy. For all intents and purposes, you don't need to know, but it's pretty amazing technology when it comes to identifying abnormalities, when we can see literally metabolic rates or metabolic changes in the rate of cellular activity that gives us indication that is the tissue normal or abnormal. But besides precancer and cancer, two other things that absorbs this wavelength is hemoglobin, which is in blood, which is actually a great benefit for us, and we'll talk about that, and then melanin. So African Americans, Asians tend to have more melanin in their tissue, so we just have to better assess or just have to be cognizant that pigmented tissue will show up as dark or black. So 99% of the time, all we're going to see is healthy green tissue. So if you notice here, I mentioned hemoglobin, so vascularity, that's where we see the hemoglobin in our vessels. But normally time, all we're going to see is, again, healthy green tissue. Again, everything you know about assessment is going to be the same, right? So when you see something of concern, what are a couple of things that you're going to do? Is it bilateral? Is it unilateral? Is it a regular shape? Obviously, now we're into winter, we're seeing more colds, and we would put the category of COVID in here too, just for a chance you have a patient with COVID, you don't know, but regardless, if there's irritation in the back of the throat, generally it's going to present itself in a bilateral presentation, which tells us this is obviously not cancerous. We know cancer doesn't grow bilaterally. However, what I would say though is, when you see it, it's definitely going to show up as a little more pronounced on the VELscope. Use it as an opportunity to have a conversation. Ms. Smith, I noticed it seems like your tonsils are a little irritated. Do you have a cold? Do you have allergy? Something like that. And the reason why I say bring it up is because it helps patient understand you're focused on soft tissue, not just teeth, right? You are oral health practitioners. You are oral health experts. And when you reference soft tissue, it helps them understand it's all about the oral cavity, not just about teeth. So if I put VELscope in your hand and said black is bad, right? Forget all the other things that what could be causing it, just black is bad. And now you see this patient's tongue and your initial response to me, oh my God, this, I see tons of black dots here. What's going on? But now your understanding of how cancer presents itself comes into play. And we know cancer doesn't grow in polka dots. It's not going to grow in random circles or shapes. Again, it's going to be unilateral or regular shape. It's going to persist. So actually what we're seeing is increased blood flow to our taste buds. In some patients, this will be more prevalent than others. Here, if you notice, now we have a black mass, and that's this concern. This would definitely say, hey, there's something going on. This is not normal. So your initial response and looking at that would be definitely, this is of concern. Mrs. Smith, do you have allergies? Do you have irritation in the back of your throat that you're cognizant of? Something like postnasal drip, something that would cause irritation. And in this case, the patient was like, oh, no, not that I know of. So, with that, we need to investigate further. But as we start to look, and it would be too obvious if I opened up the picture, you can start seeing a lot of little black sort of abnormalities. So that reduces our concern, because again, if it was just this by itself, we would definitely be concerned. But the fact we see multiple areas, but there's something going on, we need to try to ascertain what's going on. Let's have you come back in 2 weeks, Mrs. Smith. Mrs. Smith comes back, it's still there. You know what, Ms. Smith, I'm not sure what it is. My recommendation, we're going to send you to refer you to an ENT and have you get it checked out. ENT immediately biopsies. Like, I don't know what the heck it is. The only way we confirm it is through biopsy. Comes back as inflamed lymph node tissue, which is awesome, right? It's not cancer, but it then delves into what's occurring here. Long story short, this patient ended up being tested and was diagnosed with severe acid reflux and didn't even know it. One of the fastest forms of cancer fastest growing cancers in the US is esophageal cancer associated with acid reflux. I say that because, again, this isn't about squamous cell carcinoma. This is about, it's oral health and screening. And when we see this is a great opportunity to make sure this patient is getting treated if they have this condition, because again, we then reduce the likelihood potentially of that, if they're, obviously getting treated appropriately, reduce the likelihood of getting esophageal cancer. And here you can just see sort of this linear presentation, but obviously again, it's linear here. So one of the things you're going to see very frequently is orange or red, especially on the dorsal surface of the tongue. It has nothing to do with squamous cell. It's just a bacterial response, but it's a great tool for you in hygiene to say, Mrs. Smith, you probably need to brush or scrape your tongue more effectively. But I will say you should see a correlation sometimes with this and halitosis, as well as two other things, dry mouth. So this is definitely something you may want to investigate if the patient has dry mouth issues, and believe it or not, sleep apnea. We see this very frequently with sleep apnea patients. So white, green, or light in color is actually generally confirming a benign state, but just because it's light green or white doesn't mean we ignore it. It means let's investigate this further. And so, are there some sharp edges that are causing, some irritation here? Here, you sort of barely see it, but it's definitely much more pronounced on the VELscope, which led to the question, Ms. Smith, I noticed something inside of your tongue. Have you noticed that? It's like, oh yeah, every now and then my tongue gets caught between my teeth. Boom. What we can do is have the doctor come in, they'll just sort of snip that off and hopefully we'll resolve that issue from occurring. So I mentioned pigmentation, excuse me. This is absorbed by the wavelength. So again, African Americans, Asians tend to have more pigmentation in their gums. So what we need to do is just, when we see it under VELscope, or excuse me, under white light, we're going to confirm it's basically identical under VELscope. Same thing here with an amalgam tattoo. So let's say we see something that's dark now under VELscope. It seems to meet the criteria that increases our level of concern, that being it's a regular shape, it's unilateral. Obviously, we want to try to palpate it to see if there's some firmness to it, which again provides some indication of sort of how our level of concern should be. And then from that, well, how do we demonstrate or differentiate? Let's say we have a patient with a denture and we remove the denture, see a red spot. How do we really know that denture or that red spot is actually a denture sore versus something of concern? Because we don't want to assume, which is really what we do in most cases. So what we're going to do is, when we see something abnormal under the VELscope, take your Explorer or turn your mirror around in the skinny part of your mirror and gently rub across it. And here, as the hygienist rubs across it, if you notice that darkish deep maroon lesion turns green. And from that green color or light green color indicates that this lesion is a traumatic lesion or inflamed, right? So what's happening is we're removing the blood out of the epithelium as we rub across it and seeing that nice, healthy collagen-based basement membrane. So this is a great tool for you to assess an abnormality of concern versus an abnormality that is something that we can address, but obviously don't feel like we have to refer to an oral surgeon. So again, simple, what we call blanching. If this stays dark when we rub across it, that definitely elevates our concern. That would then precipitate, let's get this patient back in 2 weeks and see what happens after that period. Oops. So it's not uncommon to have irritation on, in different areas, and you can see sort of a grayish line here on the lateral border of the tongue. Now, number one, again, you have to use your clinical understanding in your assessment process. So we know oral cancer doesn't grow in a linear fashion. These tend to be bilateral, and fortunately, because of the technique we just talked about, these tend to blanch really easily, right? So when we rub across them, they turn green. But what I would tell you is, let's use this as a treatment planning tool, right? So we've gone through the process. We're confident this isn't anything of concern from a cancer perspective, but something's causing irritation. Irritation can lead to changes that we obviously don't want to occur. Mrs. Smith, we've been talking about this tooth now for the last several years. And I don't know if you guys, and I probably should have asked this, if you have a camera or an iPod with your VELscope, but if you can take a picture and show the patient this dark area, Ms. Smith, you see this dark area, this is irritation. Irritation can lead to changes that we definitely want to avoid. Let's get you scheduled finally to get this tooth taken care of. Or another mechanism could be, Mrs. Smith, this dark, I see this dark on both sides of your tongue. This is irritation. And it's probably associated with a couple of things. One being your bite. You have a small bite. What we could do is open it up and maybe reduce it. I love to, Jen's going to talk to you about Invisalign and how that could be beneficial. So think about, once you get comfortable, think about how you can use this to assist in that communication process of other treatments that you offer. Another thing, if we're squeezing regularly, probably the most common thing you're going to see is irritation associated with cheek biting or cheek sucking. Again, 98% of the time, these will blanch. Now, I would say if you have a patient and they're a chronic cheek biter and all they're doing is, sucking on their cheeks all day, this may not blanch because it's like a hematoma, it's like a deep bruise. So it definitely warrants getting them into a night guard. But again, what I would suggest is take a picture, show the patient, say, Mrs. Smith, this dark is irritation. Right now it's okay, but we don't want it to turn to something that we really want to avoid. Let's get you into a night guard and see if we can reduce that biting that you're doing. But again, most of the time, this is nothing of concern. So as I mentioned, if you remember that picture that we had different diagnoses, one of the things that's important is here's a lesion clinically that is abnormal, right? So this does not look normal. Now under VELscope, it's not normal, but when we rub across it, it turns green, right? So it blanches. So our initial inclination is, oh, it's turning green. So it's not dysplastic probably. So, let's move on. We always stress, just because something is normal under VELscope doesn't mean that we ignore it. This is part of your white light examination. Don't forget. So under your white light examination, you designate this as being abnormal. You don't know, you may not know what it is. And therefore, if you don't feel comfortable making a diagnosis, please make sure to refer. So in this case, this is diagnosis of erosive lichen planus, which means this has a higher probability of progressing to dysplasia. So obviously we want to treat this appropriately. So just because something blanches doesn't mean we ignore it. It means we just want to make sure that we have a clear understanding of what's causing it. And if we don't, please follow your standard protocols of referral. So this is a lateral border lesion that's not blanching. So this is the tongue. This is the anterior portion. This is the posterior portion on the right. And here the hygienist, as she's rubbing across it, it stays dark. And obviously, initially that would be concerned. But if it would be of concern if we didn't do a white light exam first, but we did our protocols, we did a white light exam, and this was obvious under white light exam, some deep maroon lesion. Mrs. Smith, I noticed something on the left side of your tongue. Do you know what's going on here? She's like, oh yeah, I bit the hell out of my tongue last night. And so this makes sense, right? Again, number one, we know oral cancer is not going to grow in this type of presentation. This is analogous with the bite, if you will. The reason why they're rubbing across that more posterior lesion is because it's abnormal. They ask, Mrs. Smith, I see where your bite is, where there's some marks associated with the bite. There's another little area. Do you know if it was there prior to you biting your tongue or not? It's sort of, it's got a deep red appearance to it as well. And the patient's like, no, I'm not really sure. So what they did is they had the patient come back in 2 weeks just to confirm, and this resolved. So this is an ecchymosis or hematoma, if you will, that resolved. And this is the process of assessment that really, helps you to define how to appropriately care for the patient. Now, let's just say, forget these marks. Let's say this is a lesion by itself. Patient doesn't know what caused it. It stays there for 2 weeks and it's not blanching. That would definitely increase our concerns to ensure that this patient is referred to get it appropriately assessed by a specialist. Moving forward, there we go. So we have to know what we're looking at, right? So amalgam tattoos, pigmented tissue are not going to blanch. So with that, obviously, if we pretty sure it's an amalgam tattoo, just be aware that that's what it is. It's not a dysplastic lesion. When we do that blanching technique, make sure you blanch the entire lesion up and down, left and right. Just don't go down the middle so it turns green, because you can have inflammation associated with dysplasia. So if you just blanched or rubbed across the left side, you would have thought everything's okay, but the right side actually was severe dysplasia. So one of the questions that comes up more probably from maybe a specialist that you might refer to is, what about false positives? Are we going to be referring 5,000 patients to the oral surgeon because we're going to see 5,000 dark spots, right? And the reality is, if we're really incorporating this like we should and utilizing our processes like we should, you should actually be feeling much more confident about the patients you refer. So we see something abnormal, Q&A with the patient. We then, assess, is it unilateral? Is it a regular shape? Palpation, can we palpate it? Is it firm or soft? And then obviously the blanching technique and 2-week follow-up. So when we incorporate all these processes for assessment, we should have a pretty good sense by the end of the 2 weeks and follow up. Is this something of concern or not? And that's all we're saying. Is this something of concern? If we say yes, irregular shape, abnormal, no known cause, no medical history that might warrant, a lesion formation, that means we refer, and that's all we want to do. And God willing, hopefully anything we refer is not cancer. In fact, 98% of all patients that are referred for an abnormal lesion are not cancerous. right? So I just want to stress, there are no false positives with VELscope. There are only abnormalities that require further assessment. So we showed lesions that were abnormal, many of which were benign. Now I think you'll start seeing things that would definitely put us in the category of concern that warrants a referral. So we see sort of a little, I don't know, a little scar, if you will. You may ask the patient, Mr. Smith, I noticed something back. To be honest with you, I think most people tend to overlook this. But now under VELscope, we're definitely concerned. So this is unilateral. It's a regular shape. It has a little firmness to it. And when we try to blanch it, it stays dark. From that, then, no feedback from the patient to warrant, that they're aware of that in terms of something that would have caused trauma. So after 2 weeks, it doesn't change, refers out for biopsy or a specialist who then determines biopsy is appropriate, and it comes back as CIS, which is awesome. So we caught it right before it transitions into that squamous cell carcinoma, which means we're avoiding radiation, chemotherapy, and we're not going to lose half our jaw. So this patient was referred for the polyp, and thank God they had the polyp, because looking for the polyp, they may not have found the dysplasia, the CIS located adjacent to it. If you notice, the polyp is actually benign. So if you notice here, we have a leukoplakia, and most of the time these tend to be observed. We're not observing this anymore. And the reason being is this particular one, we can see it's dark, unilateral, regular shape, does not blanch, warrants a referral, and it comes back as severe dysplasia, which is fantastic. So we're not going to lose half our tongue. We can remove this without removing a lot of muscle mass, if you will. And again, avoiding all the things associated with treatment. The reality is, though, most of these lesions you see, actually VELscope will confirm they're benign because predominantly they're hyperkeratotic. So again, even though this is unilateral, regular shape, VELscope tells the screen. Now I stress, and this is a conversation, as you have with your doctor, even though VELscope shows the screen, is it a sharp cusp? Is it an allergy? And our recommendation is if it does not resolve in a certain period of time that you're comfortable with, 6 months, 9 months, 12 months, but you're concerned it's benign, that's okay. Get a second opinion. It's always appropriate to get a second opinion if you cannot figure out what the cause of that lesion is. This patient was referred for the hemangioma lip to NYU's oral medicine department. And with that, you can see under VELscope, the oral medicine practitioner sees this lesion here. And his response is, doctor knows we do a thorough exam. He identified this as a reason to cause. So he just didn't notice the slightly raised area. And I think this really goes to the heart of the benefit of the technology, because if you did not see this, you're not missing this. VELscope increases your sensitivity by over 63%, meaning that you turn on this light, you look through it, there's something there, you're going to see it. You're not going to miss it. However, where we could miss this, obviously that's why we're increasing our probability. But I would stress, let's say you did see this under white light and you say, Ms. Smith, we want to do a VELscope exam, and the patient says no. My recommendation is, Ms. Smith, we care about you so much. We just want to make sure everything's okay. We're going to do this at no cost, just to ensure that everything's okay. And the reason why we want to do this, because in this case, this is a stage 1 squamous cell carcinoma. So it just tells you how insidious this disease is, because a lot of times we don't see these lesions until they're obvious. Unfortunately, just like before mammograms, right? You didn't, unfortunately, when you felt the lump, it was already breast cancer. And it's that same analogy with oral cancer. So this is our goal. We want to find dysplasia. We don't want to find cancer. And again, when we can screen our patients regularly, the one positive thing I would say about oral cancer is it doesn't just develop overnight. Depending on the cause, and it's interesting I say that because HPV, actually, they find HPV-related oral cancer actually progresses faster, believe it or not, than smoking-related oral cancer. But it still takes 2 to 3 years for that to occur. So if we're screening our patients regularly, we have the opportunity to find these lesions in a precancerous state. So last picture, and I I would say this really reinforces the challenge that you have as clinicians. And again, why I say thank you to you and your doctors for offering this, because it is very difficult to find changes associated with oral cancer. And here's a great example of a lesion that's very difficult to see under white light, but we can see it very clearly under VELscope. Again, unilateral, irregular shape, persists for 2 weeks, does not blanch in either visit, which warrants a referral, and this comes back as a carcinoma. So at the end of the day, we need to hopefully, as we screen our patients, we're going to avoid this from occurring because we're going to find this in a precancerous state. So one of the biggest challenges is, and I guess I would ask you to pull off, if you could unmute, do you have a mechanism to take pictures? Can you take pictures with your VELscope? You have an iPod? No, okay. So one of the things that is we think is important is you see this under VELscope, you send this to a specialist who doesn't have a VELscope, and it's a very common statement is, I don't see anything, I don't feel comfortable taking a biopsy. And then you're in this quandary, what do we do? And so we have a setup where it's an iPod Touch that attaches to a special adapter. And then from that, it attaches to the back of your VELscope. So it's magnetized. So with that, there's an app you can then download and you can take pictures, and this is an example of the app. But then what you can do here is in a HIPAA compliant manner, you can store images on the iPod. If you have Wi-Fi, or you can then email those images if you want to a specialist. You can store them in the patient's chart, but it just gives you the ability to photo document for both purposes of review. So let's say you have a patient come back in 2 weeks, you can compare, has at least a change shape or size in that 2 week period, or again, to communicate to a specialist. So the adapter is something that we offer that you can get. You can buy the iPod Touch on your own, but it's definitely something we recommend having.
Is there any other way, if we don't have that we can snap photos? I guess not, right?
It's really difficult. The one way would be to use your cell phone, but we really recommend not using your cell phone from a HIPAA compliant perspective. There's a lot of practitioners use their cell phone to take pictures, but it could get you in a lot of trouble. So
With your cell phone while looking through,
yeah,
just
but the problem is you have to have somebody holding it while you're doing and holding the mount and so forth. So it makes it very cumbersome to take, because you have to take the picture through the VELscope to get that image
Right.
of the lesion. So to be quite frank, there's really very limited options. You can't use your intraoral camera because it counteracts the fluorescence. So to answer your question, not really. Sorry.
Wait, that's okay. So if that's the case, I guess we just have to document the best we can in the chart entry where the lesion is.
Correct. And what I can do is I can send you a patient map or an oral map, and then you can use that to document where that lesion is. So if you want to communicate to someone outside of the office, at least you'll have something in a written form that you can share that provides some direction, as opposed to just saying where it is in a verbal sense. You can show them in a picture.
So I'm assuming, for liability purposes, if we see something when the doctor comes in to do the exam, we have him reconfirm it, and then he'll make the diagnosis and just whether the patient's back.
Absolutely. Great question. Yeah. So in the state of New Jersey, only a dentist can make a diagnosis.
Right. Okay, good. Okay.
Good. No, it's a really good question, because trust me, I've had situations where the hygienist is referring patients to the oral surgeon, and not saying that's bad, but the reality is from a legal perspective, it puts them in jeopardy.
Yeah.
Do you guys offer like Oral B or Sonicare?
We don't have it here, but we recommend.
Okay.
We don't sell them here.
We'll skip that. So for your information, or every now and then you're going to get someone in the medical community or an engineer, and they're going to say, hey, I've never heard about this before. Is this a gimmick or what have you? And you can really quickly tell them, hey, this is clinically founded. This is actually standard. This was at one time, it's not used as much anymore, but this was actually developed for lung cancer screening. And so there's tons of clinical data that supports the efficacy for you folks to be using it. All right, so coding and implementation. So there is a code for reimbursement, D0431, and I would say it's spotty, to be very honest with you. So where are you located, I guess, first of all, geographically? And I'm sorry, I should know that, but like,
Yeah. Good.
Well,
We're in South Jersey.
do you have a lot of state of New Jersey patients by any chance?
No, we don't.
Okay. The reason I'm saying state of New Jersey actually covers for the exam, but you know, besides that, it's really here and there based on if an employer covers it. At the end of the day, the deltas will never cover it. I'll be very honest with you, they don't give a crap, because once you get oral cancer, it becomes a medical insurance issue. So why am I gonna, you know, take 2 cents per patient alive out of my profits when it becomes a, you know, medical issue? But be that as it may, the great thing is it really doesn't matter if insurance covers or not. And I know I don't mean to say that in a flippant manner, but it's the truth. What we found is that when you charge a reasonable fee based on your area, more importantly, with providing the appropriate value to the patient, we see actually really great acceptance. Now, I would say average wise, we see probably in your area, it's going to be, or New Jersey, I'll say in general, and be central or north, central, south, it's probably an average of $20 to $25 is what the average fee is, assuming you accept insurance. And then from that, you know, maybe 20-25% of insurances may cover that. But I would tell you again, everyone's different. There's some practices that charge $70 and get 90% acceptance, and we have some practices that charge $15 and get 30% acceptance. So what we do know, it's the consistency of conversation, which is the key, or relaying the value. Do you have an idea?
So-
Well, go ahead.
I just had a quick question. So if we offer it to the patients and they refuse it, does that remove our liability? Like, are we going to come back and they'll be like, well, you had the VELscope, you didn't use it, you could have caught this earlier?
I love your question. So theoretically, because this is part of your white light examination, you are not more liable, but we do, and I will send you an example of a patient waiver that you can present to the patient to say, you know, Mrs. Smith, this basically, you'll see what the waiver says, but if they decline, now you have something that says, okay, you know, you've declined it from having. But as long as you're, what I would say, Carly, the key is, it isn't whether or not a patient declined, it's consistency and you writing it in the chart. So first thing, we don't want to pick and choose who we offer it to. And sometimes we get in this habit because, you know, we're running behind and all of a sudden, you know, we find we're starting to pull it out only when we see something suspicious. And it's going to be that one patient that's that 25-year-old healthy athlete that gets oral cancer. And that's the one that's going to literally kill you from a legal perspective. So we want to be consistent in offering it to every patient. I recommend, if you're going to have a waiver, then just get everyone to sign it. There you have something available for the chart, or at least make sure you put it in the patient's chart that you offered the VELscope and they declined. That, from a legal perspective, will protect you.
Okay.
So I'm stealing this from a practice that had 90+% acceptance in rural Kentucky. They were very, very methodical in their assessment process, or excuse me, they were very methodical in trying different things to try to determine what works and what doesn't work. And I just thought they were really creative in sort of looking at wording, looking at who talks about it. So what they did was they provided information when that patient, so when that patient comes in, you know, sign their name or what have you, they were, at first, I think they were giving a VELscope brochure, then they just ended up giving them sort of like a little sheet that they wrote up, or a lamination. Hey, Mrs. Smith, this is something that we're now doing, something we want to, you know, and obviously your patients, your regular patients probably already know this, but this is something that we're establishing as our standard of care in our practice, something the doctor wants every patient to have. You know, take a second to read this. If you have any questions, you can ask hygienist or doctor when you go back. So now, instead of looking at their phone or reading People magazine, they're reading about the benefits of this examination, HPV, because no one knows about HPV and oral cancer. You know, obviously that it's safe. for some patients, regardless of what we may think, we reference how it's, Dr. Oz and the doctors. So it does provide some credibility for some patients because of that. So now they go back. Now they have value, right? Now they know there's some value to this exam, which is critical, in my opinion, to getting patient acceptance. And what this office determined was it actually saved time too, because you're not having to answer 20 questions when the patient gets back. So from a hygiene perspective, it was a time saver. So now, you just say, hey, Mr. Smith, we're going to be doing a VELscope exam. It just allows us to see things we can't see with our naked eyes, but it's simple, it's safe and painless, and it shouldn't take more than a couple minutes. Shall we move forward, right? And then generally what you're going to find is they're going to say, do we have any questions? And then generally it's going to be, well, is this covered by my insurance, right? That'll be maybe the most common question. And so very creative. So if you go to Delta Dental's fee schedule in New Jersey, it has it listed at, I can't remember, it's $59 or $65. But what you can simply say is, Mr. Smith, the normal cost of the procedure is $65, but you know what? The great thing with your insurance, the most you're going to pay out of pocket is $24, whatever you're going to charge. Shall we move forward? And the reason being is if it's covered, it's covered. If it is, it is. You're not going to waste time determining, again, for something that's going to be only $24. But the reality is it's also to reinforce to the patient that you are providing this at a discount if you look at whatever the established fee schedule is. So I just thought this was very creative. It makes it simple and addresses, I think, that basic concern. And I think there is great value for something that's only $24 when you compare this to, mammograms that are, thousands of dollars, pap smears that, I think are $180+ and other forms of screening. That makes sense. I'll also provide you, though, I'll send you some additional verbiage examples for everyone to have. So, you can determine what might sort of fit with your personality and or approach that you want to take. So obviously, if we find something you'd already asked this question, obviously this is up to the doctor to determine what happens next. But you are referring for evaluation. We're never referring for a biopsy because it's going to be up to that specialist determines if a biopsy is necessary. One of the things that I would highly recommend, though, that you should consider doing if you don't have one already is find an ENT in your area to refer to, and for two reasons. First and foremost, actually three reasons. First reason is more of these lesions tend to be further back of the throat, which I think is in the purview of ENT. Secondly, it goes under medical insurance, so it doesn't impact their dental insurance like it can if you refer to an oral surgeon. The third reason and benefit is if you establish that relationship, you're going to get referrals from these ENTs. I'm telling you, these ENTs see, patients with serious dental issues all the time, and actually they can't perform certain procedures unless their periodontal disease is under control. So definitely worth establishing a rapport with some ENTs in your area. Last thing that I want to address, so let's say, and this is where the photo documentation again could be very beneficial, is if you see something suspicious, you're not really sure what to do, what you can do is provide history of the patient, no names, 59-year-old male, high blood pressure, on whatever medications. We have to have pictures, though, of white light and under VELscope. And then we actually refer these to world-renowned oral medicine and oral pathologist specialists that will provide a report to you that says, hey, this is no big deal, or this is something that needs to be referred immediately for potential biopsy. And that service is currently free. So, okay, real quick, obviously, you know how to do a VELscope exam, but I'll just reinforce goggles are for the patient. You do not have to be concerned about any eye damage. Follow your normal protocols. Unilateral or regular shape persists for 2 weeks. If you notice here, two things that are important is distance. So we want to be about 2 to 3 inches or closer from the oral cavity. The further way away, the less the light's going to penetrate the tissue. So again, we want to be fairly close. And think about that distance is going to remain the same whether we're looking at the buccal mucosa or obviously the back of the throat. So again, we just want to have that same distance from the back of the front. In terms of your distance from the end of the VELscope, everyone's different. Normal inclination is to put it up to your eyes. If you want to be 2 or 3 inches away, I think tends to be the norm. If you wear loops, I don't know if anyone wear loops, you can establish your normal distance first with your loops on, and then you bring the VELscope in so you can actually look through your loops and do a VELscope exam that way. So I highly recommend, if you're used to doing your white light examination with your loops, do that examination through the VELscope. Now, it takes a little getting used to. It's about 5 to 10 patients to get comfortable with that sort of that distance kind of thing. But once you get comfortable with it, at least most people that I know that wear loops, feel very comfortable doing it. One thing I would just stress, and I apologize, I think I said this, but I apologize for repeating myself. Please let the patient know ahead of time. Ms. Smith, we're going to start doing your exam. Again, this is safe. There's no pain. There's no radiation. You're going to feel a little warmth, and you're going to hear a little fan noise. The reason why it's important to tell them, you're going to have 1% of patients, unless you warn them there's a little warmth, they think it's going to burn them. So just let them know there's a little warmth, but again, it's completely safe, nothing of concern. As I referenced, if you wear loops, you can see the distance here. In terms of the distance, if you wear loops, want to stress, we have 2 things that we definitely want to make sure we're using: our VEL sheath, which goes over the unit, and then our VEL cap that goes in the front of the unit. These are disposable, but this is the number 1 reason why these units get sent back in, is because people are using disinfectant inside of this lens. The disinfectant leaks behind the lens and ends up killing the LEDs. The LEDs are the most expensive part of this technology, believe it or not. They're specially made in like 5 different parts from across the world. And so it's going to end up saving you significant dollars by making sure we are keeping this lens on here. If you get dust, just use a lint-free dust, but we never want to use any liquid here on the lens or the base of the handpiece. That's it. So questions, concerns, issues? Did I address all of your questions?
Just looking. Yeah, we got the insurance code and the charges. I know. Anybody have any questions?
I don't think so. Quite yet.
No. So just real quickly, none of us have ever used this before.
Okay.
So your recommendation for, covering every area, how do we physically do that in the mouth? We start from one area. Do we take the tongue out? What do we do?
Okay, great. So think about how you do your white light exam right now. It's sort of a white light oral cancer exam, right? So you usually start on one side and you work your way over. So you're going to follow that same protocol. But 2 things, and thank you for your question. So I should have brought this up. We want to be as perpendicular to the tissue that we're looking at as possible. So when it comes to your cheeks, for instance, most people just retract and they look straight ahead. What I want you to do is turn that patient's cheek and look contralaterally, right? So we're going to be looking through from one opposite side, if you will. The other thing is with the tongue, if you're used to using gauze, for instance, and you're holding the tongue, usually you have a free hand now to sort of manipulate and get exposure. You're not going to have that free hand anymore because you're going to be holding the VELscope. So one suggestion would be to have the patient stick out their tongue. Mrs. Smith, can you stick out your tongue and move it to the left, right? So let them do that. And then what you can do is use your mirror to get further exposure if you need to look further back if for whatever reason the patient has a fat tongue or what have you. So those would be
Right.
2, recommendations to get further exposure. The other thing would be make sure you're getting that palate. I think it's very common. Most people sort of really skim over the palate. We want to make sure to get exposure. So have the patient move their head up. Obviously, so you can look up to see the palate. And then lastly, we have to get good exposure at the back of the throat. And I know this is probably the most challenging thing when it comes to an oral cancer exam, is that big long enough so we can see back. So you want to get that use that depressor, or use your mirror to get that exposure. My recommendation, and the recommendation actually from oral pathologist, or excuse me, oral medicine practitioner recommendation is when you do your initial exam, have the patient sit up actually, at least if they do the portion, because it's if they're laying back, the tongue wants to go back, obviously, when you're doing that so it's a little easier
Right.
sometimes when they're sitting up. So That's really, but really you're just following what you're currently doing. I'm going to send you another video that is really a quick sort of example of what that examination looks like externally. So hopefully that'll provide a little insight. But again, if you're comfortable doing a white light exam, we're following the same process. The only two things we're changing is how we're presenting it to the lateral borders of the tongue and the cheeks.
Okay, and this is obviously all just non-keratinized tissue, so it's all soft tissue. Like you can't, outside the
Correct.
face, you can't do. Okay,
Correct.
all right. Anybody else, girls? Okay, so you'll send the video of today's, and then also the two other things that you had mentioned, the diagram and the waiver you'll be able to send to us?
Correct. So I'm going to send you two different emails. One's going to be this video. And next will be a video of the exam itself done by this world-renowned oral pathologist. And then you're going to get a second one, which will incorporate some documents. Will be the map, the waiver, and a couple other things that you might find beneficial.
Awesome. And how long would you say this, like, it should take us? Like in the beginning, should it be like 4 minutes, 3 minutes, 10 minutes? What does it look like when you're first doing it?
To do the exam, VELscope exam itself, I mean, it shouldn't take you, well, when you first start off, maybe if you're being, extra, I guess, just from a time perspective,
Right.
A minute and a half, 2 minutes max. But usually most people do it within a minute and a half to do a third. I mean, think about how much time it takes you to do a white light exam, right? So
Okay.
most people do that in about 30 seconds.
Right.
So if you see something, you blanch it, no more than a minute and a half to 2.
Okay, terrific.
Okay.
Anybody else? Okay.
I have a quick suggestion, if I may. Eben, would you be willing to just go over the implementation of the adapter and the iPod if the office decides to maybe look into that?
Sure. So I think, and I'll send you a video on sort of what it looks like too, as that third video in there. So this is the adapter, and it attaches to, there's 4 spots. So it attaches to the back of the VELscope in 2 ways, vertically or horizontally. And then what you do is you just put that iPod Touch, something you can get from Best Buy or Apple, and it attaches to the VELscope, and then you download the VELscope app. And then you take pictures too, and it doesn't show up really well on the camera, but there's an app you download, it's free, and then you can take those pictures in a HIPAA compliant manner and store them and so forth. It's actually, I'd say, pretty cool, and it provides details too, and then you can email those pictures directly to the patient, or excuse me, directly to a specialist or to yourselves if you so matter. So I'll send you a little video so you can share that with the doctor to see if that's something that you want. I think if you start using it for a little bit, I think you really see, and in reality, it's actually not associated with VELscope related lesions. I think you'll find it's actually going to be more of a tool for communication to the patient for things that you may want to consider recommending to the patient, like night guards or as I mentioned, Invisalign or something like that.
And
So
suggest retail?
So retail, okay, so this is a good question. So retail it's through your dealer, it's about $314. If it's something you guys decide you want to get, even though technically we sell through dealers, this is one thing we provide for existing users for $199.
So our VELscope is pretty old, and we don't have those 4 little.
No, it comes with the adapter, so it's all part of the adapter
So it
itself.
doesn't matter the age of the VELscope, we'd be able to get the adapter for that.
Correct. Just as long as it's this model, it's
Yes. Yep. Okay.
Alrighty.
Yep. All right. So you'll send that stuff to us, and then we could further look, at least watch it again so we get some, knowledge of it a little bit better.
Yes, ma'am. And you have my contact information. So if you have any questions or need, just let me know. But with that, all it is start to use it. So I know that you're thinking about charging. My suggestion is, last suggestion would be do it on 10 to 20 patients. So maybe, your first day or 2, just do it on everybody, even if they decline it. And that's your learning curve. You should feel more than comfortable by that time in terms of how to use it. And really the comfort is more associated with your angles than it is what you're seeing, because you're not going to see oral cancer, I guarantee it. Well, I should not guarantee, but it's highly unlikely you're going to find oral cancer, but you're going to see a trauma, you'll see a cheek bite. And again, in that day or two of using it, you're going to feel comfortable.
Okay. And what about like telling the patient, the first time we're going to do it, for free, and then we're going to have to charge out for it? Like next year we'll be charging out. Is that something you'd recommend?
Well, if you're going to do that, absolutely. I think it provides definite value. I would say two things. I would say first that this is a 60, and I think it's appropriate to say this is the $65 value test. As a standard, we establish a baseline. And so what we're doing, because we feel this is so important, we do this initial exam for free. But next year, this is part of our standard protocol. And the great thing is it's only $25, and boom, now you have it set up. Oh, I'm sorry, I apologize. One last thing that does remind me though. We had a very large group that uses a VELscope, and they did a really interesting assessment because they looked at practices where they got approval first year, and then they had a certain amount of practices whose approval declined the second year. So patients didn't accept it after that first initial exam. And they found the practices that tend to have consistent acceptance year after year, the practitioner was explaining what they were doing through the exam. So as you're doing it, Ms. Smith, I'm looking at your cheeks. Oh, I notice you're biting a little bit, but everything's okay. Now I'm going what we call the vestibule. Now I'm looking at your other cheek. Everything's fine. Yeah, I see a little cheek biting. Now I'm looking, can you put your tongue down? Now I'm looking at the floor of your mouth. Now stick out your tongue for me. Lateral borders of the tongue look fine. So what they found is that when the patients were hearing that conversation or actually statement, it really dramatically increased their value propositions. The practices that were just doing the exam, okay, Mr. I'll do a VELscope exam, a minute and a half later, they were done, or everything's okay. Those patients, they were not less likely, but they had less patients accepting. So highly recommend have a conversation with or explain to the patient what you're doing. So to your point, as you're moving forward in terms of getting that patient to accept it the next year, they'll remember that conversation or the explanation of what you're doing through.
Okay, that makes sense.
Yeah. You guys are awesome. I thank you so much for, again, being part of the cause, getting on board. No offense to our doctor, but I would tell you, we tend to find more patients get screened. And more importantly, we get a little more time to spend with our patients when it comes to that screening process. So,
yeah.
But if there's anything else you need, once you get the information, please don't hesitate to give me a call. And
awesome.
Hopefully we'll have an opportunity to follow up with you to see how things are doing.
All right. Thank you so much. I appreciate it.
Thank you. Have a great day.
You too. Bye-bye.
Bye-bye.